Okay. Good morning, everyone. Today, it's our pleasure to invite the best guest today to supervise on this special topic, Dr. Sunjun Son. She's actually the co-resident. I was the co-resident, the colleague in Colombia, working with me. He's a very talented doctor. Let me introduce his background briefly. Dr. Son graduated from Kyunhee University in 2006, and afterwards he worked in private practice for several years, and he
Yeah.
pursued his career in United States and Manhattan in Columbia University in press program. He graduated in 2000. Which year you
19.
graduated?
Yeah.
19.
2019. Yeah.
Graduated in 2019. And he was actually so talented that he got hired as the assistant professor right now in Columbia University. And he's also the program director in pre-doc cross program. Dr. Son has multiple, different research, and also his thesis is focusing on this special topic, mentioning about the I would say the contour of around implant tissue in various abutment. And we just talked about his previous thesis. He was analyzing, the pontic, not the abutment side, with the different graft procedure and with different abutment design, and it alters the outcome. So today he has this special selection of the article that we are going to, discuss in depth about how the soft tissue will changes and appears around the different implant abutments. So we are going to continue with the first article that Dr. Jessica Cole will present it. So why don't you pop up your article right now? Yeah. So the title of the article will be Histological and Micro CT Analysis of Peri-implant Soft Tissue, Peri-implant Soft and Hard Tissue Healing on Implants with Different Healing Abutment Configurations. So Dr. Cole, please get started.
Introduction. We all know that after implant placement, peri-implant bone remodeling occurs to establish peri-implant biological width. So the goal of implant treatment is long-term survival and success. And to do so, we need to ensure that peri-implant soft and hard tissue is stable. But how? Platform switching is a well-documented approach, but evidence on the effect of different abutment designs for minimizing bone remodeling is scarce. So the aim of this original research is to assess the effect of different transmucosal abutment configurations on the peri-implant soft and hard tissue healing. Materials and methods. In short, it's a two-piece dental implant placed in 4 beagle dogs. These dogs were all well taken care of, aged between 12 to 15 months, weighing 10 to 12 kilograms. The fixtures and healing abutments were made of pure titanium. 2 different transmucosal healing abutments were used. One is the wide emergence profile with a 45-degree angulation. The other is a narrow emergence profile with a 15-degree angulation. 2 implants in each dog, totaling 8 implants in each group. So a total of 16 implants were included in the analysis of this study. In more detail, 3 surgical stages were performed. The first stage, extraction of 4 mandibular premolars and 1 first molar. The roots were hemisected, intrasulcular incisions were used, and they were removed with elevators. Then the teeth were cleaned every 2 days with a toothbrush embedded in chlorhexidine gel. After a 3-month healing period, the second surgery stage, implants were placed on both sides of the mandible, at least 4 millimeters apart and 1 millimeter subcrestally. Implants had a platform switching design with 0.3 millimeter horizontal offset and conical internal connection. The size of the fixtures were 3.5 millimeters in diameter and 8 millimeters in length. Then, after a 4-month healing period, the animals were sacrificed and the mandibles were sectioned. Biopsies were examined with a radiographic micro-CT system. Figure A is the wide emergence profile, and Figure B is the narrow emergence profile. The landmarks, as we can see on the figures, IS is implant shoulder, BC is marginal bone crest, FBIC is first bone to implant contact. The dimensions are defined by the vertical distance of the two landmarks. So we can see implant shoulder to bone crest, implant shoulder to first bone to implant contact, and lastly HBA, horizontal bone apposition, which means the horizontal distance of implant platform to the greatest inward extent of bone ingrowth on the implant shoulder. And for the histological samples, they were fixed, prepped, grounded, and stained with HE and von Giesen stain. Landmarks we can identify from top to bottom. MML is marginal mucosal level. ABE is apical barrier epithelium. BC is marginal bone crest. IS is implant shoulder. FBIC is first bone to implant contact. Dimensions of soft tissue are the height and length of MML to FBIC, which forms a biological compartment. And the dimensions of hard tissue are similar to the micro-CT scans. For the results, gross histological description. After 4 months of healing, both groups presented keratinized oral epithelium, which is continuous with the barrier epithelium. And as we can see on the healing abutment extending to the implant platform, there is dense connective tissue. And at the implant abutment interface, the WE group presented less area of connective tissue compartment compared to the narrow emergence profile. The micro-CT analysis, all findings showed significant differences between the two groups. In the first row, negative result, negative 0.54 of IS to BC in the WE group means that the location of the marginal ridge is apical to the implant shoulder, whereas in the NE group, the bone crest is 0.76 millimeters coronal to the implant shoulder. The second row, IS to FBIC mean is 1.11 millimeters in the WE and 0.12 millimeters in the NE. The last row, HBA, none of the WE groups presented horizontal bone apposition, and in the NE group, 62.5% presented HBA. The results for histometric analysis, the dimensions of peri-implant soft tissue, although no significant differences were shown, but apical displacements of the marginal peri-implant soft tissue in those sites with WE are found, as we can see in the first row. Dimensions in the peri-implant hard tissue, the bottom half, showed statistically significant differences between the two groups. IS to BC, mean difference is 0.6 millimeters, and IS to first bone to implant contact, mean difference is 0.59 millimeters. Now for the discussion. Biological compartment is confined by A, alveolar bone, B, implant shoulder, and C, implant abutment. And this compartment is critical for organization and direction of the collagen fibers. Also, establishment of peri-implant biological width. So when we take a look at the vertical component, the abutment, the scenario is this. When a wider and more divergent abutment is used, the inner wall of the compartment is located closer to the marginal alveolar bone, so it limits the space for the peri-implant biological width. And because it is limited, the bone remodels to accommodate the newly formed attachment, which results in more bone loss than the narrow and straight abutment. The second discussion topic talks about CAD/CAM technology as a reliable way to fabricate implant abutment and frameworks because of its proper marginal fit of the restorative prosthesis, low risk of biological and technical complications, and we can also decide just exactly how wide or how narrow we want our final abutment to be. The conclusion of this paper is that the design of the transmucosal component can influence the establishment of the peri-implant biological width. And if we use a flat and wide emergence profile, it induces apical placement of the peri-implant biological width and induces more alveolar bone loss. So my critique for this paper is that for further translational studies, we may need larger sample sizes because in this study, standard deviation is close to or even higher than the mean. And also in this study, we used 45 and 15-degree abutments, but we may need more variations of abutment designs. If more variations are included, perhaps a more specific criteria or range can be identified as a clinical guideline. And lastly, take-home message. A narrow and more straight contour designed abutment showed superior bone stability and soft tissue level. And with this concept of slim abutments in mind, digital technology CAD/CAM can be used for the designing and customization of implant transmucosal component.
I think that was a great summary, Dr. Kuo. Thank you for the presentation.
Mm-hmm.
Thank you.
So, okay. So this article, basically, it's a histological data that they want to, demonstrate how the abutment actually influenced the peri-implant hard tissue and soft tissue, the peri-implant components. So let's have Dr. Son to make a quick summary and also have some critique about how you presented. But for the last, for the highlight for today, Dr. Song will also give a short presentation going through all this concept along with his research and his cases to demonstrate and elaborate how the abutment it actually influenced the peri-implant soft tissue and how the importance of it. So, Dr. Song, please.
So I like this article because it's thought-provoking. I would say, at least when I started out doing implant dentistry, I would use any kind of prefabricated titanium healing abutment, not thinking about the morphology, that it would lead to some ramifications. Morphology, now we have to think about the material of choice because we have a variety of material, titanium, sometimes ceramic, PEEK, and so on and so forth. So all of those things could contribute to the healing rate and how excellent or not the healing might be, and also how the bone might remodel. I don't think a lot of people have been thinking about whether the divergence, the degree of divergence of the abutment itself may be contributing to the degree of bone remodeling, because after the wound healing phase is finalized, biologic with supracrestal attachment, I think that's the more recent terminology, is reformed, and this healing abutment, or maybe even the abutment itself, when it's immediately provisionalized, can be a profounding factor in that healing process. So Dr. D'Souza kindly provided this preclinical study, and I think if I add one more point in the critique would be that this is still a preclinical study. It's a canine model, small sample, but I think the biggest benefit is that it really is thought-provoking and gives us a certain trend that perhaps going super wide is not the best way to approach these cases. At least for me, I would be guilty of molar sites. I would want to have the widest healing abutment possible if I can't do a custom healing abutment. In that case, if we go by this article, by this scientific data, then I might have been inducing more bone loss than necessary. That being said, I agree with Dr. Kuo that perhaps there should be a wide scale clinical, possibly RCT, a randomized control trial, with variance in degrees of the divergence of the abutment itself. I think at least one thing that we might be, at least for myself, that was confusing is we've been taught and we've learned to appreciate in at least extraction sockets to do a custom healing abutment, a fully customized healing abutment, which we'll be talking about later, and a full contour provisional. In that case, perhaps that emergence angle, when we're looking at it from a cross-sectional view, we might have been overlooking the importance of the emergence angle itself by trying to make a natural emergence profile, emergence angle, whichever terminology we want to use. Sometimes it's a little bit confusing. For me, I would say I can elaborate a little bit later. I want a very sleek and narrow emergence right from the crest module, the top of the implant. That part I want it as straight as possible, possibly platform switched, and then gradually, nothing sudden, gradually converge into, conform into the natural morphology that we are targeting. So for that, another concept will be the vertical component, which we deem running room, prosthetic space also. That should be adequate, and that could be variable in different sites in the mouth. So there's a lot of moving parts, and these authors are trying to shed light in a scientific way to give us some clinical guidance. So I think this is a very good opening article. And then the actual clinical review will be the next article from Dr. Chu.
I cannot agree with Dr. Song more because we actually talk about the selection of the article and how we were trained from, Columbia, from our background, knowledge inherited from Dr. Tarnow and his team. We focus on this abutment a lot, and throughout the time, along with the history of how they provide our education with more evidence, the paradigm actually of the knowledge switched slightly. As Dr. Tong just mentioned, originally we tried to respect this contour, restoring it as mimicking the nature, nature shape of the tooth. However, with more evidence and science, we might consider slightly different. As he just elaborated, as he just addressed, we might want to have at the provisional phase, we might want to have a narrower abutment to and slightly gradually go flare out. So Dr. Song will probably discuss this more in his later presentation. But as for the critique, I also agree with Dr. Song and Dr. Jessica Kuo. This sample size is relatively small. However, when you look upon this type of clinical, I would say the animal study, the value, you cannot undermine the value because it's very difficult to compile this type of study in vivo. So how we do and we take out from this data, regardless of the sample size, and we understand that the standard deviation is close to the mean, sometimes larger to the mean, but they did show the trend of how the different configuration affect the peri-implant hard and soft tissue, which is critical because after how the biological width has established, we frequently consider, the abutment will only alter the soft tissue instead of the hard tissue. So that's how my takeaway, and I was pretty impressed with this article, how they compiled it.
Mm-hmm.
Okay, so let's carry on to, it's very good. Dr. Jessica Gould, you did a good job. So let's carry on to the second article. Dr. Lin, she is going to present this article by Stephen Chu. And the title of the article is Restorative Emergence Profile for Single Tooth Implants in Healing Periodontal Patients, Clinical Guidelines and Decision-Making Strategies. So Dr. Lin, please get started.
Okay, good morning, everyone. So
Before we start, I want to talk about periodontium and peri-implant soft tissue. So, actually, peri-implant soft tissue like periodontium contain circular epithelium, junction epithelium, and fibrous connective tissue. But the difference between them are the natural tooth has sharpest fiber, which is perpendicular to long axis of the tooth. But for implant, it does not contain this fiber, so the peri-implant soft tissue is less resistant to clinical probing and biofilm penetration. So to maintain the peri-implant health, the contour of implant abutment extending from platform to gingival margin is quite important. And this divergence is called implant restorative emergence profile, which should be established properly. And the implant restorative emergence profile, which is called the IREP, is a three-dimensional shape of subgingival and supragingival contour. So it arises from the implant restorative platform into the gingival margin. And the goal of designing such contour is to maximize the aesthetic appearance of the definitive restoration and allow proper oral hygiene. And the aim of this article is to review the currently available evidence related to the design of contour of the IREP and to provide recommendations and a decision tree for clinical practice and reference with consideration of the dental implant position. So we will talk about the subgingival contour first. Actually, the subgingival contour can be subdivided into two categories. One is the subcritical and critical contour. The critical contour is defined as an area extending from the vaginal margin 1.0 to 1.5 millimeter apically, which you can see from the picture in the center. The blue line will be the critical contour. And for the subcritical contour, which is located immediately corner to the implant platform, let's extend to the critical contour, which is the green and the red line area. Okay. And the subcritical contour location was mentioned, as I mentioned before, and its function is to provide a gradual and harmonious transition from the implant platform to the critical contour. So for this area, we will need a sufficient rolling room, which Dr. Song mentioned before, which is the implant depth. We have to have enough implant depth to create this area. And for the dimension, the apical coronal dimension will vary depending on the level of depth at which the implant is placed. And this area, this subcritical contour will be affected by palatal or facial position of the implant, and also affected by the angulation of the implant. So in this contour, we can divide it into three categories, which is straight, concave, or convex, depending whether you want to support the gingival tissue or you want to decrease pressure from the gingiva. And Steinman has proposed a guideline about prosthetic design in 2014 and on the International Journal of Periodontic Restorative Dentistry. They conclude that if the implant is placed in the palatal location, a convex contour at the facial side should be used to support the marginal soft tissue. And Inhofe and Nan and Radimani and Ropan, their article has suggested to use a concave subcritical contour at the facial aspect if the implant is placed in a labial incisor position, while Roman further analyzed an experimental abutment with a concave subcritical contour and showed an absence of peri-implant soft tissue recession in 87% of the case after 2 years of definitive restoration. So this is all about the mid-facial area. And as for the interproximal areas, Cooper suggests a slightly concave contour to minimize excessive pressure and thus reduce the potential resorption of the adjacent bone. And so we can make a brief conclusion that at the mid-facial location, a concave subcritical profile is often recommended. But if the implant is placed facially, we can use a flat or concave contour. But if the implant is placed too incisively, we may need a slightly convex to flat contour. And if the implant is placed palatal,y we may use a convex contour to support the gingiva. And for interproximal area, we mostly use the slightly concave to straight profile. But in the rare cases, if the papillary support is required, we can use a convex profile. And for critical contour, the critical contour is still in a subgingival position in relation to the pregingival margin. So in the natural tooth, this area is around the CJ and between the root surface and the anatomical crown. So it is often convex in order to support the pregingival margin, or what we call the zenith. By adjusting them, we can determine the gingival margin level, and we can change the architecture, and thus the cervical morphology of the clinical crown can be adjusted. So since the final restoration should follow the contour of contralateral tooth, the critical contour should also mimic the area. So regardless of the implant position, whether we are placed anywhere, so the critical contour is set by the contour of the crown. So sometimes where there is insufficient implant depth or the gingival recession is shown, the critical contour may be made at the supra or equal gingival position, which is very rare. So the design of critical subcritical contour will be affected by both implant position and angulation. And both this contour should be the same for whether you are making a cement type or screw retain implant processes. So as for ideal implant position, there is little consensus on the spatial position of a dental implant, but the author of this article suggests an ideal implant position in the anterior teeth to be 3 to 4 millimeter in the coronal apical position from the soft tissue twist, and slightly palatal to the line that bisect the buccal-gingival position of the final restoration, with a singular sagittal angulation. So, and also the distance to the adjusted measure tooth should be at least 1.5 millimeter. And as we mentioned before, an ideally designed single implant and restorative emergence profile supports a harmonious gingival architecture, and the soft tissue can be non-surgically sculpted with a provisional crown prior to impression making. So in interdental area, Pato et al. Has suggested the head compare the effect of concave and straight abutment on the papillary field of single implant restoration, and they found no significant difference in terms of patient satisfaction, pink aesthetic score, or soft tissue ability between the straight and the concave type of abutment shapes. And Redmani reported tendency of papilla loss with divergent subcritical contour. So maybe we can draw to a conclusion that at the interdental area, a straight or concave contour may be better. And there are two critical factors that can affect the shape of IREP. One is the vertical soft tissue dimension, which is the implant depth, and another is the horizontal soft tissue dimension, which is the periodontal biotype, or what we call the thin or thick biotype of the gingiva, or the gingiva thickness. So as for the vertical soft tissue dimension, the peri-implant soft tissue complex is similar to the dental gingiva complex that both possess a vertical dimension about 3 millimeter. So it also consists of circular junctional epithelial and connective tissue. But the biggest difference is the quality of the connective tissue attachment. As we mentioned before, in implant there is no perpendicular fiber insertion, so it is easily so it's more like similar to a scar tissue around dental implant. So the peri-implant soft tissue is less resistant to clinical probing and biofilm penetration comparing to natural tooth. And so in implant placed to subcrystallise maybe over 3 millimeter, it may result in additional bone remodeling above the implant abutment junction, and it will increase the probing depth and may pose a challenge of maintaining stability of peri-implant soft tissue. And on the contrast, lack of implant depth or the vertical soft tissue thickness may pose a significant challenge to restorative dentists. So as the picture on the right side, the contour are usually less than ideal, and maintaining the hygiene in this area will be very difficult. So, and for the horizontal soft tissue dimension, the width of the dental gingival complex around natural tooth at this area will be 1 to 1.5 millimeter in thickness, and measuring 1 to 2 millimeter from the pre-gingival margin. And intentional palatal positioning of the for the screw retain implants. This thickness, the horizontal thickness of facial tissue, may be over 2 millimeter. So we may require convex contour to support the gingiva from the proper position. And for the implant is placed to angulate to facially, this area we may need to provide a flat or concave contour to minimize the labial pressure on the peri-implant soft tissue. So we can allow the soft tissue to migrate in a more coronal position. So Chu in 2015 analyzed the outcome of facial palatal ridge dimension and shape and the peri-implant soft tissue thickness. It divides the patients, 45 patients in 4 groups. One is the conventional flat healing abutment as a control group. So you have no bone graft and it's a flat abutment. And the second group is the immediate anatomical restoration without grafting materials. You just use the provisional only. And the third group is a conventional healing abutment with a grafting procedure. And the fourth group is the immediate anatomical restoration with bone graft procedure. So you both have the bone graft and the provision at the site. So the results show that placing a bone graft and with an anatomical provisional restoration will reduce facial palatal ridge collapse to less than 0.2 millimeter and increase peri-implant soft tissue dimension by 0.5 to 1 millimeter compared to the control group. So the peri-implant tissue framework should mimic the shape of the anatomical root whenever possible. And for the horizontal soft tissue dimension, in median implant restoration, we have 3 choices. But we can either use the divergent healing abutment, which you can see on the right side of the top of the picture, or we can use a customized abutment, or you can use a provisional abutments. So when compared to the circular shape healing abutment, the anatomical shape provisional crown could potentially increase the soft tissue support because its ability to mimic the cross section from the root, and it can be easily adjusted. So the customized abutment and provisional restoration are used most. So it has been suggested to utilize screw retain provisional crowns whenever possible. So because it can both eliminate the risk of residual cement and increase the horizontal soft tissue thickness. Okay. To increase the soft tissue dimension, we can also use the platform switch design, and it can offer an advantage in subcrystal contour because the reduced diameter places little pressure on the surrounding bone and soft tissue. And so the author have draw conclusion into this decision tree. You can see that the emergence profile is divided into 2 categories, 2 parts. The left side is the critical contour, and the right side is subcritical contour. So the critical contour it consists circumferentially from gingival margin to approximately 1.5 millimeter apically, and it determines the gingival margin architecture. So it will affect the aesthetic outcome. This part should be ideally developed to mimic the contralateral tooth, where the implant is positioned. So it is mostly convex because you have to follow a cervical morphology of the anatomical crown, or you can either use a straight or concave contour in cases of excessive labial implant placement or angulation.
And at the right side is the subcritical contour. Uh, in thick ins, sorry, and facial side, if you are facing a thick gingival bow type, you can use the concave subcritical contour because it will enhance peri-implant tissue thickness. But in thin gingival bow type, which is in Asia we will face the most, you may need to use the convex subcritical contour at the labial surface to get more soft tissue support. And niche facially, if the implant is placed too facially, you may need to use the flat or concave profile. But if the implant is placed incisively, you can use the slightly convex to flat to meet the critical contour. And if the implant is placed too palatally, you can use a convex profile to support the soft tissue. And for interproximal area, we mostly is slightly concave or straight contour. And if the papillary support is required, we can also use the convex profile in the interproximal area. So in some instances, a connective tissue graft may be required to convert the gingival phenotype from the thin to thick for the purpose of enhancing aesthetics. So the conclusion is the proposed decision tree have provided guideline for which to utilize. And based on currently available literature, there's a lack of convincing evidence that noted in the term of ideal REP design. Sorry. And the conclusion is that the critical and subcritical contour of the crown or abutment complex should mimic the anatomical tooth shape as much as possible to provide adequate tissue support. And the REP is dependent upon implant position and periodontal phenotype. So the take-home message will be the picture we mentioned above, the decision tree flow chart. And my personal opinion is the contour from the occlusal view was not mentioned much, and also the consideration of the soft tissue augmentation was not included in the decision tree. But actually, if you add this part, the decision tree might be too complicated. And another one is the selection of abutment material for better aesthetic outcome, especially in thin gingival belt type was also not mentioned. And that's all for today. Thank you for your listening.
Okay. That was a good review. The reason, so I'm gonna pass along to Dr. Song. He has prepared a presentation for this, but I would like to give like a quick review of how, why we select this art. I mean, Dr. Song and I select the article. Dr. Song basically, know about this article insight, but also with me, I would say this is a good article for reviewing this topic up to 2018. I still remember 2018, it was actually the year Joseph Kahn came to give a speech. That's a keynote speech in Taiwan. And he mentioned about this article and how difficult that they all compile, they squeeze out their valuable time because they're all, the top stream doctors, that they try to collaborate all these articles and their personal opinion from the past years, and then try to focus on this critical topic about how abutment correlate to peri-implant soft tissue and the contour, as I said. And the feature of this article, I would say it's a good review of what that current knowledge at the time and what's the parameters that they look into to potentially affect this contour. The decision tree gives us a general picture about how we should shape the contour. However, the detail is it's still after I finish this article, the detail of how I should fabricate the provisional or definitive abutment, the actual shape and how critical and subcritical zone, how we, configure it. It's still somewhat not as scientific addressed in this article. And I think that's also why there's still a lot of articles and research compiling for this topic, because this is such a unknown and difficult area that we look into with any type of evidence for now. So let's pass the final critique and summary to Dr. Song. Dr. Song, please.
Oh, thank you for the great presentation. I really do like this article, but I agree 100% with Dr. Cole because yes, we are lacking a lot of scientific evidence due to a lot will be our responsibility as the clinicians. But if you think about it in a practical standpoint, doing scientific research on this topic, looking for those subtle changes is very easily said, but very, very difficult to do. So not using that as an excuse, but that is one of the reasons that we're lacking scientific evidence, and everyone has their own approach because I wouldn't say any of them are wrong. And probably it works really well in their hands and the patient population that they have. One thing that I do want to emphasize is that everyone included in the authorship in this article works in the US. So it's a very diverse community, but at the same time, let's say Taiwan, it will be more homogeneous, like South Korea. So for us, if I try to retrace back to my time there in my hometown, almost every single patient is thin biotype. They're thin phenotype. Asians are predominantly thin phenotype. It's very, very difficult, challenging clinical situations. So I would say we have to approach it a little bit more carefully. And when the tissue is less forgiving like that, the ramifications from small miscalculations here and there can pile up and blow up in our faces. So I think it's a little bit more challenging with the population that I used to deal with and what you have to deal with nowadays. So we have to take caution. And the other thing is when we talk about concave, convex, all of that is very subtle difference. It's not like we make it very bulbous or completely collapsed in. It's very subtle difference, like slightly concave, slightly convex, or rather straight. It's just trying to micromanage the tissue because we're working in a very, very small field. The field of focus is very, very small, one single tooth, two teeth. Yes, it can be applied to a full arch as well, but even if it's a full arch, the mouth is a very small organ, if we can call it that way. That would be my other consideration. If we want to mention briefly about the abutment of choice, most of these authors, I don't know for entirety, but let's say Dr. Chu, his predominant abutment of choice is gold-plated metal, and it's very, very beautiful, very expensive, but very, very beautiful, aesthetically pleasing, a lot of advantages. Ceramic material might be the material that Dr. Lin was elaborating or alluding towards. I think it is great, but ceramic looking white doesn't mean that when you put it into underneath soft tissue that it looks actually white. It has this grayish hue that is a big, big problem for us. And then for me, I use a hybrid concept. I always use a titanium abutment, so titanium fixture to titanium base, and then a zirconia abutment or the zirconia crown itself. So still the material limitations will persist. Soft tissue augmentation, that's a very good point. And one of the authors here, Dr. Khan, does a lot of, I think his approach is a lot of connective tissue grafts, autogenous. That's great. And I would say that gives you tremendous favorable results, but it's also morbid at the same time. We have to harvest, and it's an additional surgical intervention. Not saying that is impossible for a lot of the great clinicians out there. It will be like routine procedure, but if we can simplify it, if we can make it more simple, more approachable, I think that's the key. Making it easy, there's no downside in it, and that's why all of these great minds have been talking about the topic and trying to gather some thoughts. So now, without further delay, I'll
So
share
Dr. Song,
my yeah.
please share your screen. And while
Yeah.
he's working on that, I totally agree with what you said. So let's be more specific. When looking at the parameters, Dr. Lin, she just mentioned about, the volume of soft tissue and the quality
Mm-hmm.
of the soft tissue. So basically, these are things that might, these are the things might have to consider while, discussing about the contour of this abutment. And also the abutment has been
Yes,
categorized in
absolutely.
different
Yeah.
area, right? So how the tissue, the quality and quantity of tissue correlate to the area that we mentioned over here, the critical and
Mm-hmm.
subcritical zone, and how it alters, before we talked about augmentation or the material itself and how it appear, how it affects the aesthetics. I think only focusing, even the data that only focusing on these parameters, these two factors, it's very limited. I would say I haven't seen any of these articles. So that's the
Mm-hmm.
area I think we should look into more. So why don't we have you share your screen already?
Yeah. Can you see it?
Okay, perfect. So
Yeah.
let's
I think.
welcome
Yeah.
Dr. Song to introduce this
Thank
topic.
you.
He's literally the expert. I would say he is we have been discussed a lot, and along with Dr. Dennis Tarno's team, he inherited the most of the knowledge, the current data, in this field. So let's welcome Dr. Song to present this
Thank
topic.
you. Yeah. So this is kind of a short communication, not really a big presentation, but just sharing the topic and discussing some pointers that I think is pertinent to leading to favorable clinical outcomes, because that's at the end of the day, that will be our goal as clinicians, clinician scientists, whatever you want to describe yourself. I think we want happy patients, and then we will be happy clinicians as well. So implant restoration emergence profile, a lot of people use different terminology, but basically emergence profile would be the terminology of choice, at least for myself. It was originally originated from natural teeth. The concept of emergence profile comes from Dr. Stein and um, I think MDT Kuwata from Japan. So here I'm showing one of my cases. This was after first disengagement with a provisional, the soft tissue. I think it was very nicely captured in my photo. The patient is African American. So again, the host factor is a big element. In this case, we have very good tissue, a very nice healing, and a very favorable situation. So let's go back to the terminology. I usually like to start with going over the terminology. We all know what it is, but sometimes it's good to refresh. And here I'm using the glossary of prosthodontic terms as my reference. The emergence profile is the contour of a tooth or a restoration. It can be applied to both, such as the crown on a natural tooth or a dental implant or dental implant abutment, as it relates to the emergence from the circumscribed soft tissue. So what we knew is basically it. There's nothing new to it or different. But I think it's really nice to always remind ourselves what the parameters of a certain terminology entails. So brief literature review will consist of this article. I thought about including it, but I think it's a derivative from the Su et al. Article first talking about the critical contour and subcritical contour. The authors here describe the subgingival aspect into 3 zones. Zone E, which will be aesthetic zone, B will be biologic, C will be crestal bone. And their design proposal is E should be slightly convex, B is dependent on the clinical circumstance, and C would be rather straight. So there's a very certain steady tendency of having the emergence, the direct emergence from the crest module of the implant rather straight. I think there's a big benefit in that. And also, if you look carefully into different dental implant manufacturers, there is also a steady trend of making the neck the crest module part of the dental implant narrow. There is a certain tendency of that, a certain trend. And I like it, and I believe that will lead to better outcomes. So the very famous Su et al. Article that first described critical contour and subcritical contour is a group from UPenn, and the same authors, mainly the same authors, I wouldn't say revised, they reiterated their concept in 2020, and then there is a certain clinical recommendations which will follow shortly. So this was pertinent this was related just to single implant crowns when they were explaining the concept, and it's not scientifically reinforced fully to this day. And certainly at that time, it was more of a position that they took. This is what we do and we found favorable and we should consider. So we talked about the critical contour a lot, and I have another diagram later, and I will give my opinion about it. So critical contour will be such like this. Here, A, B, D, P, M is basically just looking at it from an apical view, buccal, distal, mesial, and palatal view. So critical contour is talking about not just from one side. It's a three-dimensional representation of how this morphology is looking like. So Dr. Chu's article, Dr. Chu elaborates that emergence profile should be considered in a three-dimensional manner because everything is three-dimensional. There's nothing linear. There's nothing one-dimensional, two-dimensional. We are just taught to think about things in a one-dimensional and two-dimensional way for convenience purpose. But actually everything is three-dimensional, including you and me. So the second article by the same group from UPenn, the first author in this case was Oscar Gonzalez Martin from Spain. They are giving us clinical recommendations, just like Dr. Chu's article, and it pretty much coincides. The critical contour, they would want it, initially it was exact, but now they're promoting for a reduced 0.5 millimeter, 500 microns, interproximal equal to natural tooth, palatal equal to natural tooth. Subcritical will be as concave as possible all around. So their idea changed to subcritical can be any way you want for clinical convenience to let's do concave. And I tend to agree with that. The one thing that I would say is the facial reduced 0.5 millimeter. It would be more so that we encounter a certain element of recession and resorption after any tooth is extracted. So that would be compensating for that. But who can measure 500 microns? So this, I would say, take it with within common sense that we have to try to mimic the natural morphology as much as possible, but with a slightly decreased contour. I'd say that would be very safe to take. And also one thing that I do want to mention, and Dr. Ko and I agree with this. Actually, she gave me the idea and I agree with it 100%. Critical contour, at least for us two, it doesn't mean just subcritical 1 millimeter or 1.5 millimeter. We think the immediate super gingival contour is equally, if not more, crucial. So the emergence profile of a typical natural tooth is rather straight. Contrary to what a lot of us think, that teeth might be concave there or convex there. A lot of the extracted teeth, if we look at it very, very carefully from a sagittal point of view, they are emerging straight. So that emergence profile, that contour matters a lot too. And I have more success when I control that better with my provisional or definitive restoration than the cases that I make it bulbous or concave or such like that. So for me, and I think for Dr. Ko as well, this is very, very absolutely critical. The immediate one or 1.5 millimeter supragingival and subgingival. I wanted to really emphasize that.
Yeah,
So
maybe you can talk a little bit more
yeah,
about that later on. Yeah, at the end.
yeah,
Because a lot
yeah,
of people, and also that's the one of my concern about what Dr. Chu's article, because that's slightly different from what Joseph Kahn was mentioning at the podium, because they wrap up as the critical zone, only focusing on whatever below the Frisian margin,
yeah,
right? So
yeah,
please
yeah.
continue.
I think eventually it's all very subtle differences. Like for instance, if we're taking into account Dr. Khan or Dr. Chu, their work is like out of the chart, beyond level.
Right.
So even when we're talking about these slight differences, concavity, convex, like it will be very, very subtle, and they're reading the individual clinical situations very, very carefully.
Right.
So everyone cites this article, and I think is valuable enough to mention Dr. Steegman and Wang, and it's a 2014 article. Again, this article also doesn't have scientific evidence, but it's more of a opinion or a position article. When the implant is located slightly labially, they propose for a concave emergence profile because, again, the implant is leaning towards the buccal. When it's centered, we can go slightly concave. When it's palatal, when it's really in the back of the mouth, then we want to plump out the tissue and make it convex. This is more controversial in our time right now because we're trying very, very hard not to be too palatal or too labial. Also, because now we understand more about the thickness and the thickness of the tissue, both vertically and horizontally, maybe convex morphology would not be that beneficial. So again, this has to go back to reading the individual clinical circumstances as carefully as possible. So the rationale is denoted below, but I tend to not agree with it 100%. So this is from Dr. Chu's article. We went over this, so we don't have to repeat it. But one sentence that I do want to read one more time is that emergence profile is highly dependent upon implant position and periodontal phenotype. For us, like who've done this enough, we get various implant positions, even the ones that I place. Like, I'm not trying to blame any of my surgical counterparts. There's always a lot more to it than face value. But even the ones that I place, some of them are more ideal, some of them are less ideal. And then the periodontal phenotype, the host factor, a lot of times it can be very harsh. So all of those has to be considered, and we have a more multifaceted way of approaching this.
And over
There's
here,
another concept.
sorry.
Yes.
Before you
Yeah.
carry on, I
Yeah.
also want to address a little bit. In terms of, I think this is so valuable, like the implant position. As I mentioned, previously, the periodontal phenotype as well as the implant position. But what makes the implant position critical, the crucial part, it's also three-dimensional, as you first addressed.
Yes.
It's never, buccolingual or, it's never one perspective that you're looking into. However, even with the latest technology, with the simulation of the implant, we tend to only look at from one cross-section view. So basically, you're focusing on the most, it's the buccolingual dimension. You want to make sure what the position, whether it's correct or not. But this implant position, I frequently, like I always remind myself, it is the position itself as well as the angulation, how it comes out towards to coronal, and also the depth of it, as you mentioned briefly, that's the running room. So it's not only three-dimensional, the buccolingual, mesial, distal, but it also is the depth for the running room as well as the angulation, because the angulation, it eventually affects the implant position, and it gets more complicated for an abutment to consider when you at the end when you need to design it. So again, you elaborate what the 2014, the PRD, Hong Lei Wang, they compile for what's supposed to, the pottery, if you think about it, they want to support the tissue slightly with the contour within convex. However, you literally need to approach it in a very precise and very settled way. It is, I would say, from my limited practice, experience, I have very limited chance to really do like a bulky, shape. And a lot of people actually ask about that, because you think about it, the immediate implant placement, frequently, like 90% of the time, we intentionally place it pottery because we try to engage with the bone. We try to restore it as a screw return prosthesis. So a lot of the audience, when I lecture this topic, they always ask, so based upon the implant placement, the concept, so 100% like you're doing the convex instead of what we keep talking about, the concave shape. So this is the part that, I try to think over and over again and see how I can, introduce a little bit better with, basically we want the convex, even with the palatal position. You look at the three-dimensional perspective, you look at the angulation. When it comes to the coronal part, as we mentioned, the critical area, which in my humble opinion, that's above and below the phrygian margin, which can both matter. But that area is only supporting the tissue. It's not really the full convex. It's the area that's supporting the tissue, mimicking the contralateral, mimicking the natural look. But it's never the entire whole, the shape of itself. It's convex.
Yes, absolutely. I can't agree more. As for me, the ideal implant position might be slightly different from operator to operator. For me, how I try to plan and execute is I try to ride the incisal ledge. I don't like placing implants too palatally. It will be very difficult because of the material limitations that we have, even now with so many options. If you place it too palatally, I would even not place it immediately if I can't place it where I want it to be. A lot of times the prosthesis itself might look really nice from the facial, but if you look at it from an occlusal view, it will look very, very ridiculous. And the patient, we never know, because I don't have an implant yet. Maybe I will in the future, but if I would imagine that something is protruding towards my palate, that will be so uncomfortable. So sometimes I think we overlook that. Again, it's not just a case, it's a human being. It's not an empty space. It's not even a tooth, it's not even a mouth, it's a human being that we're treating. So we are thinking about their betterment. Our patient, their betterment. It's not just about the looks, it has to be hygienic, it has to be closer to natural. So my implant position is always trying to go to more so the center part. Dr. Chu elaborated really well that it's slightly palatal, but a lot of times it's very difficult to control that and ending up very, very palatal.
Exactly.
So that is, one thing that I always try to caution and be away from.
Because remember, Dr. Arnold always mentioned about 2-3 millimeter rules before. And the 2 millimeter, actually, when you look at the center of 2 millimeter with a standard 4 millimeter diameter implant, sometimes when you engage entire center, 2 millimeter of the implant from the center, which is a 4 millimeter diameter implant, towards the palate, when at lateral inside, at the anterior area, depending on the remaining bone after the extraction, sometimes when, let's say, in canine area, the diameter of the tooth has been huge already. So trying to engage and only controlling that 2 millimeter, even 2 millimeter, sometimes that's a lot towards the palate, and they lean towards to the angulation at the end coming out through the cingulum. That is very palatable, right? So sorry. So carry
absolutely.
on. I'm sorry.
Yeah. Absolutely, especially like if you're thinking about a mandible or maybe mandible anterior or like lateral incisor, it's so difficult.
It's just
Yeah. So this is a very different concept, but I think it really warrants some recognition. This is 2013, Dr. De Giri from Italy, and I really like this concept. It's called a chamber concept. And what chamber means that he's trying to create a soft tissue chamber. So he was really ahead of his time, because at that time everyone's thinking about bone and how to maintain bone. No one was really talking about soft tissue that much. But he was using an ankylose system, and ankylose happened to have a heavily platform switched abutment. And with that, he's inducing soft tissue ingrowth and making a very robust soft tissue chamber. So I think this is a very interesting concept, and it's kind of close to what we are talking about, as the immediate emergence itself has to be rather straight, and we prefer platform switch. And so this is the extreme example that was present 10 years ago. And the article that was mentioned, the Rompen et al., it was making very similar in some sense to Dr. DeGizi's concept. It was a clinical trial, and they found favorable result in terms of tissue healing and tissue aesthetic scores. But this article also, the sample size is very limited, and I can't even imagine how difficult it must have been to do the study. So it's making a very, very exaggerated concave abutment and trying to, again, bring in the tissue. And in the article, they say they call it a connective tissue ring. It's almost like a ring that forms around the abutment. And it's a very interesting approach and attempt in trying to elaborate how the supragingival part can contribute immensely to the outcome. This is Dr. Zazusa's article. Hopefully it will be followed up by a clinical study as well with a bigger sample size. I really do think this is very, very interesting, but we also do have to think about, again, individual clinical circumstances. What if we place a 4mm implant in a molar site? There's no other way but to immerse rather widely. So in those situations, perhaps we have to do that. Losing that much of bone, in theory, if it's not pathologic, if it's physiologic, then it wouldn't really deter the route of the prognosis. But I think, again, the value of this study is that even the emergence angle can be a factor, and we were overlooking it. And the other important aspect about all of this is that we as a clinician and the operator have to have a very good understanding of, we're talking about contour, but what are these teeth supposed to look like? So this is a study by Dr. Avila Ortiz's group from Iowa. They scanned extracted teeth, and it's showing coronal section right at the CEJ, and how the maxillary and mandibular, each teeth are very, very different. So having this understanding, we're talking about how to micromanage 0.5 millimeter. So if we're talking about that, then we absolutely require an understanding of how that tooth is supposed to look like. A suture incisor compared to a lateral incisor compared to a canine, they all look different. PM1, PM2, maxilla mandible, they all look different. So we have to have that understanding, and then we can even take it further and talk about having a concave 0.5 millimeter or not. So I think this article, I love this article. It came out in 2021. Very, very easily shows that we should have a good understanding of how natural teeth are supposed to look like. So I want to share some of my clinical cases and elaborate further how I apply this in my own practice. This would be following the more recent trend. The emergence itself from the titanium base is very sleek, and then I try to make it gradual, but to a certain degree, it has a wide angle above, away from the crest module, away from the top of the implant, but where it's meeting the critical contour area. So this is titanium base, zirconia, and layered porcelain. crown. It's the day of insertion. No, actually, this is 18 months follow-up. So those two crowns are number 7 and 10. In your case, it will be called 12 and 22. Yeah, 12 and 22.
12, yes, 12 and 22.
Yeah, 12 and 22. Yeah. So again, we placed a lot of attention in the subgingival area and also the supragingival area to try to mimic nature as much as possible. The clinical circumstance behind this is the patient had bilateral lateral agenesis, so you never had those laterals. We're trying to create something that never existed and try to blend it in as much as possible. I like number 10 much more than number 7, but I like the left side more than the right side. I try to do the same thing for both, but for some reason, they have some variance. But all in all, I really like this case.
Mhm.
So this is the X-ray, PA X-rays, and we can see how the contour itself is and how I tried my best to not make any sharp edges, but then preserve that critical contour and make a certain amount of free space for the soft tissue to fill in. And my provisional before this was very much following this concept as well. Minimal bone loss, when we respect nature, I would say, the outcome will follow. And this will be one of my, the study that Dr. Cole was mentioning. This was part of my master thesis. And the idea behind this was to extract a tooth, a hopeless tooth, and then graft the site. In this case, we used allograft and provisionalize with a pontic. The idea of using a provisional pontic was to have a prosthetic socket seal. So we're sealing the wound and maintaining the morphology as much as possible. And then later on, this can be, we follow the original prosthetic plan of whether it be an FPD or implant, doesn't really matter at that point. So if we go back to the left side figure, after extraction, I grabbed, following the dual zone socket management protocol by Dr. Turno and Dr. Chu, I grabbed all the way to the free gingival margin. I'm using a 2-unit mesial cantilever provisional restoration. So in the middle is my provisional restoration. I think that is 1 week post-op. So basically, it really, really helps the healing, induces, like promotes better healing, because very minimal remodeling is our goal. And in 6 months post-operative, the pontic recipient site is very healthy, well-formed, and we can appreciate, if you compare the left side to the right side, there's very minimal amount of changes. This is one of my better cases, a thick phenotype. The loss in this case in linear measurement is about 0.24 millimeters in height, 0.2-ish in vertical. So basically we preserved the whole thing. And then why does this matter? Like, why do we have to painfully, making those provisionals is not that easy. Making the pontic is not that easy. But why do we do that? Because it can lead to results like this. I don't think I can recreate this from a healed site. Well, that is a healed site, but a healed site that has not been preserved, like how we approached it. So the definitive restoration is one single crown, a zirconia crown, number 12, for us is 7, and number 8 is a single implant. The tissue was never elevated, it was never flapped, it was flapless, guided surgery, and the x-ray looks like this. So in this case, I do have to have a wide emergence because that's I think that was a 4.1 millimeter Straumann RC, so a standard regular platform implant, but the tooth is quite wide, so we do have to emerge like that. Again, we try to manage the contour itself to not be sharp anywhere and preserve the critical contour that we very, very painfully try to preserve. So this is the reason we want to respect nature and respect the critical contour concept that we have been talking about. Now, can this work in Pontics alone? Let's forget about implants for just a minute. I know we were talking about implants predominantly today. This is another case that I recently finished. In this case, the patient had, again, congenital lateral incisor missing, so lateral agenesis. And previous dental history consists of canine substitution. Canine substitution means that the previous provider moved the canine to the lateral position, so the lateral is actually canine. And usually that kind of orthodontic treatment concludes with space closure, meaning that the premolars come forward, the canine moves forward, and recontour as restorative needs requires. But in my patient's case, the canine was moved to the lateral position. There was an empty space and 2 implants were placed. If we have an opportunity later, I can show you the whole case, but for today's purpose, I'm just showing the final results. We dealt with the clinical situation, and we have a distal cantilever. It's a big taboo in the pros world, but I don't think necessarily it applies to every single clinical situation. When it's done right, it can be maintained. And I'm banking on the fact that the occlusion was more favorable to me. And this is 1 week follow-up, I want to say. Distal cantilever. So the canines are pontics, and the lateral incisor / canines are the abutment teeth. The result, nothing is perfect. None of these cases are perfect, but the result itself, again, we're following biological principle that we know of today. We might find more exciting facts later on in the future. I hope so. But as of now, we're following the scientific facts and the clinical experiences that these giants share with us, and I am utilizing that. In this situation, it's an ovate pontic in the pontic sites, the canine sites. It's a shallow ovate pontic, contrary to my study protocol, which had a 3 millimeter depth ovate pontic. So in this situation, I wanted to have possible, so I made about a millimeter depth ovate pontic, a shallow ovate pontic, promoting hygiene, and the final result I think is acceptable. And this is the post-operative after cementation PAs showing how constricted the space was. So I do a lot of bold stuff, but in this situation, I refrain myself from trying to place an implant. And with this, I would want to say thank you and conclude the small presentation I prepared. And if there's any more discussion, there's a lot of.
I would say for those 3 cases, they are perfect. You're very humble with the result. It's amazing. Like that's the thing, like I think a lot of people, a lot of dentists, they know how difficult to manipulate all this tissue with this narrow space, but they just don't know how much knowledge actually behind it and how precise you are actually considering and evaluating each parameters before you proceed to the next. So these gives us a very good value of how how you approach the cases precisely in order to preserve the optimal outcome. Just just like you've never lost it.
Yeah.
So I would say
Exactly.
the result it's amazing, and that's because you're taking it seriously with your knowledge, because knowledge is the foundation. You have to know what you have to proceed, how you're going to proceed for each step precisely. Then you reflect with your skill, and for both,
Exactly.
these are very difficult.
Exactly. So I don't think it's an approachable way if you have to bend backwards every single time. So you have to find a way that works really well in your hands. You have to understand what your hands can do, what your knowledge can partake, and then you advance from there on. So like I don't think we have to. I like the articles that we shared today, but I don't think we have to drive ourselves miserable to a degree that, oh, I missed a half a millimeter, it's the end of the world. I don't believe or nor I can always deliver that. So I think the key is to take this and then keep on practicing and just get better and better every single day. Like if I'm better than yesterday, that's still a big win.
Yeah, you
And
will
the result
eventually,
really tells you.
right? You will
Yeah.
eventually do
And the,
something good. Okay, so thank
yeah,
you. So
exactly.
yeah, again, I cherish this opportunity a lot because it will be recorded. But these are the discussion that we continue, over
Mhm.
time, periodically. We discuss about, and that is also what I want to deliver to the residents. There's never a day that you end your learning, because manipulating all this area, single implant, single tooth, it's as difficult as the full mouth rehab. And it's actually more difficult because you have to recreate the nature, presenting it
Yeah,
as it's never
absolutely.
been lost.
Absolutely.
Exactly. So each step you have to really think through. Like when people say, I'm trying my best, you're not trying your best because you need to first study.
Exactly.
You have to first study. You have to have the background knowledge before you try
Yeah.
your best. If you don't study enough, you just never try your best. You're just trying
Exactly.
with your skill to do something on this, human being without a
Yeah.
predictable result. So what I really appreciate how you reflect your three, phenomenal cases is in order to achieve that level, see how much, fundamental background that you have been trained and you continue to pursue the latest knowledge. And that is what I highly acknowledge, and I really appreciate how you gave us this little but wonderful case presentation at the end. So
Can I say one last thing? I think
yeah,
this statement is really interesting. It's from Dr. Stein, and Dr. Stein gets credit for advocating for modified ridge lab pontic that we use readily. I still use modified ridge lab pontic a lot, even though I did my study on UV pontics. So he said in his article in 1966, the dentist should not attempt to duplicate nature exactly, but should attempt to support it by supplying a prosthesis based on sound biomechanics principles. I think the way he explained it at that time, like 50, 60 years ago, might be slightly different because there were so many technological limitations back then. But even to this day, especially related to implant dentistry, perhaps we should not try to duplicate it exactly, but then utilize all of this techniques and material science and try to make something that is based on sound biomechanics principles. So I think that is maybe perhaps the best we can do, and then we just keep on improving from there on. I think that's a very good start.
very good. And that requires a lot of hard work and fundamental knowledge that you
Yeah.
have to continue on studying, and that's what I want to deliver to
Yeah.
all the residents again.
Yeah.
Okay. Thank you very much. So why don't both of
Okay.
the doctors appears up to the podium? Dr. Lin and Dr. Kuo. Why don't you? Yeah, they're sharing. Good. Okay. We have one last question that they would like to ask. Jessica, why don't you read it there for us?
Great, thanks for today's topic. I would like to ask how we can precisely depict the emergence profile with lab technician, as they may have no radiograph reference when fabricating CAD/CAM abutments.
I would say the question would try what the question was implying should be transferring. How should I advise my lab technician
Mhm.
or transfer the transferring the critical zone. So there are two. Okay, so there are two different things, right? One is how we transfer what we have captured, and the other one is if there is not so the design hasn't been as settled, and we have to try to modify or recreate what the abutment should be, supposed to be. If song.
Sorry. Could you repeat that? Sorry about that.
Right. So, basically, I think what the question was implying is that, how can you precisely depict the emergent profile with the lab technician? So there are two different parts, right? One is what you have duplicate, what you have fabricated already, and you're just duplicating it, transferring it to your technician. The other one is you probably don't have a settled shape of the emergence profile yet, and you want to modify it or improve it better. How are you going to instruct your technician? So why don't we focus on how you transferring it?
I think that's a really good question, and it's very difficult. I mean, at least for me, and I would say for a lot of us out there, because our understanding and a technical standpoint from our ceramists and technicians might be slightly different. So what they might have been taught how to do and what we have been teaching ourselves how to do might be slightly different. So we have to get together and be on the same page. A lot of communication is required. All of the cases that I shared today doesn't really have the morphology of the tooth to be extracted. Like it was all starting. The prosthesis itself is all starting from a seemingly healed site. So from there on, I do my calculation. I usually do my wax up still to this day manually with a conventional wax up, and then I get my contour. And then from there on, we're connecting the dots. So if there's an implant, we have where the top of the implant is going to be. And then the contour, that's the reason I shared that cervical contour slide. So I understand that. And then I will tell my technician, go about a millimeter or millimeter and a half straight down, and then connect the dots from there on, from the crest module to my 1 millimeter subgingival part, and then I will review it with him. I will review the result with my ceramist technician, and then if there are to be any modifications, that we discuss about it. I don't think we can just tell our ceramists or technicians do this and then it just magically appears. There has to be like a very long period of calibration, and even at that point, in some cases, might be too difficult. But later on, we would want to have a more automated or more streamlined process. And the advent of artificial intelligence and machine learning will help us with this. But until that day, and even at that day, we as an operator still have to make the clinical decisions. We have to relay the information to the ceramist technicians, and again, back and forth communication. I think that's the biggest key.
Correct. So basically, you have to, as I said, the extraction side, you have to try to at least recreate the contour as the first step, as you said, and you connecting. And for the critical zone, it's always critical because clinically, the soft tissue, you have to observe how it reacts immediately, right after, whether it's the surgical procedure or you're just doing after the wound healing. So basically, the manipulating the tissue is the first thought, and then you connecting. You can instruct from there further, but you always need to revise with your technician. It will never be, you give them some information or give them some radiographs. They can automatically just generate this amazing result. Because again, the knowledge is beholding on your hand, so you have to deliver that. And even the knowledge, sometimes you're unsure of, so you cannot fully, understand and process. Then how can technician replicate what you actually want? Is difficult. So as you said, revising the design back and forth, sometimes, taking extra time, that's necessary, especially in this very critical aesthetic zone.
Yeah, it's very unforgiving.
Correct. Okay, so I think we're ending at here a little bit over time, but this is so valuable that the discussion that we had today. Thank you again, Dr. Son. You are the best for this field. As far as I know, you really work hard on it, and the case is seriously. I saw the eyes because they're at the background stage. I saw their eyes when they saw the case. Can you guys pick like which were actually implants and which are teeth? They actually cannot. You know, it's phenomenal. So,
Thank you.
and today we also appreciate the two residents. They did a good job on presenting it. So thank you, and we're looking forward to the
Thank
next
you as
session
well.
that you share more with us. Okay.
Yeah, thank you.
All
Thank you
right.
for having me.
Thank you.
Thank
Have a great
you,
day.
Dr. Song.
Thanks. Have a good night. Bye.
Bye.